Ladies and gentlemen, welcome to the specialty update. We, the College of Physicians, in collaboration with Sri Lanka College of Sexual Health and HIV Medicine, we have this specialty update on HIV and related illnesses, which will be important for the medical registrars, scene registrars and medical consultants. And we welcome Dr. Priyantha Veer Singh and the consultants from the STD and HIV, which is same. And to start the proceedings, I invite Dr. Sandipana Gamage, who has been instrumental in arranging this along with the College of Sexual Health and HIV Medicine. He's a moderator and he's been the man behind the scene who has got the thing going. And it is Dr. Sandipana Gamage.
Good afternoon, everyone. Thank you, Dr. Fuldisanayaka, for that kind word of introduction. So, first of all, I would like to invite our resource persons of the first panel discussion to come to the stage. Dr. Fuldisanayaka, Dr. Varuni Pannala, and Dr. Geethani Samaravira. And Nalaka can come when the case is being started. Okay, welcome to the first panel discussion of the program, Thinking Beyond Tuberculosis. So to begin the program, let me introduce our panelists who will be sharing their insights about this program. And Dr. Upul Disanayaka, Senior Consultant Physician, National Hospital, Sri Lanka. Dr. Varuni Pannala, Consultant Venerologist from STD Clinic, Chilao. Dr. Geethani Samaravira, Consultant Venerologist, National STD AIDS Control Program. Dr. Nalaka Kulatunga, Senior Registrar in Venerology, National STD AIDS Control Program. So we will start our discussion with the real case scenario. So Dr. Nalaka, you can start the case.
Good afternoon to everyone, dear sir and madam, colleagues. So let me introduce the first case scenario today. So this is a 49-year-old married man presented to a medical ward with a gradual weight loss over 2 years duration, which has become apparent during last 4 months, and also has developed cough, intermittent low-grade fever, and loss of appetite for the 4 months duration. And latter part, he has developed breathlessness and wheezing. And going back to his history, during last 4 years, he has experiencing frequent episodes of respiratory tract infections, and also he has been feeling unwell, which as investigated by his family physician. And last 2 years, he has developed chronic cough, which is a dry cough. And incidental finding of low hemoglobin was also there in his history.
Okay, Dr. Upul Disanayaka, as a senior consultant physician, I'm sure you would have encountered so many similar kind of patients in your career. So if a similar type of patients present to you with a history of recurrent chest infections and history of weight loss, so what is your initial approach?
49-year-old man with cough, weight loss, but duration is about 4 years. Say the duration is important, the weight loss is important, and the cough is important. So common things being common, my first diagnosis is tuberculosis, because it's a long lasting illness which goes on causing symptoms. The other causes for cough, which causes loss of weight, which goes on, like bronchial carcinoma. Probably if you take this history seriously, you will not be thinking, because a bronchial carcinoma person will not last 4 years. The other things like bronchiectasis, yes, possible. A patient with bronchiectasis will have ongoing cough because of the illness, the ill health, inflammatory reactions. He will have loss of appetite, therefore lose weight, and on and off they will start coughing. What are the other possibilities? Say if you consider other causes like recurrent cough, like asthma is possible, but then you can't explain the weight loss and the fever. And then the other thing, interstitial lung disease, cough, yes, intermittent fevers, yes, weight loss, yes. So my differential diagnosis is TB, TB, and TB.
So coming back to the history, during last 4 months, as I mentioned earlier, he has been experiencing intermittent low-grade fever with night sweats and loss of appetite, and he has in fact investigated for the tuberculosis a couple of times, and TB was ruled out during that investigations, and later on he was given inhaled bronchodilators, but the response was very poor. And 6 weeks prior to the admission, he has developed breathlessness, especially on exertion. So patient got admitted to the ward. On admission, patient was emaciated. He was pale, and there was oral candidiasis. And on examination, there were no apparent lymphadenopathy, and the respiratory tract examination was largely not significant. Basic investigations revealed that low HB of 7.4 with ESR 64, and liver function and the renal function tests were within normal range. And again in the ward, TB was screened and it was negative, and the chest X-ray was, you can see here, and it was with the chest X-ray findings, it was diagnosed as atypical pneumonia and the treatment was started, but the response was again poor.
Okay, now excluding TB here, now a couple of sputum examinations were negative and gene expert also negative. So, Dr. Upul, so do you still consider TB here, or what do you think? So do you want to look for other causes, or how do you investigate this patient?
I would still consider TB as the cause. Now, yes, gene expert is a very sensitive, very specific thing in the order of 90s. But it all depends on the sample that you send. Unless you cough out phlegm and send that sample, if the sputum does not contain acid-fast bacilli, the sample might be inadequate. He has a ESR of 70 and he has a chest X-ray suggestive of TB. I would still consider TB, and I'll send sputum AFB for culture. Then you have to consider other possibilities now. Yes, so whether now when you have a long, now if you go back to the basics, respiratory tract infections which is going on, either you have treated them inadequately, you have an infection which is resistant to the antibiotic that you give, or your immune system is not good. So as for your immune system, you're not, there's no history of tuberculosis, diabetes. And then there is, now he's a married man, 49-year-old. He's a faithful husband. I would believe him. And then the other possibilities like atypical TB, milioidosis, but milioidosis this long. So I would go for TB, but on the other hand, now I have my doubts as to whether he has something else in the chest.
So would you like to think about acquired immunodeficiency like retroviral? So faithfulness of a man, I don't know whether it is just because of that he's married.
He's 49.
Yes. Okay.
Yes, people can be naughty before that, yes. Yes, especially now this audience, when we are discussing HIV, you will be all thinking of HIV here, right? But when this patient comes to your ward, would you be thinking of HIV? No. You will be reluctant even to ask whether there is a sexual indiscretion in the past. So HIV is possible, yes.
With the poor response, further investigations were initiated. As said, the immunosuppression was there. I mean, they were thinking, so they have referred the patient to the STD clinic. HIV became positive and the CD4 count was very low, 42. And among the other investigations they have done, LDH was also high. So with these findings and investigation results, the respiratory symptoms were recategorized to pneumocystis jirovecii pneumonia, because he has, in addition to that, he has actually a significant exercise-induced oxygen desaturation as well. And anemia was largely attributed to the anemia of chronic disease. And before winding up, little bit about his social history. Though he is 49, he has been separated from the wife for last 10 years, and later on he has actually had some MSM exposures in his life.
Okay, right. So, patient who presented with recurrent chest infections, so with a history of weight loss, ultimately turned out to be a patient with advanced HIV, complicating with PJP pneumonia. So it seems like this patient's diagnosis was delayed, and then there were several missed opportunities from us as well. So Dr. Geethani, so could you tell us about advanced HIV disease and how common it is in Sri Lanka and how they present to us?
Yes, thank you, Dr. Sandeepana. As you can see, this graph shows the number of new diagnoses from 2010 to 2023. As you can see, the numbers are steadily going up, with especially number of males diagnosis going up. And during 2023 alone, we had 694 new cases diagnosed. So if you analyze these cases carefully, the CD4 count at presentation, nearly 25%, more than 25% are diagnosed at a very late stage of HIV with a CD4 count less than 200. So if you go into histories of those patients similar to this case, we see that there are several missed opportunities. So these patients, when they initially present with milder symptoms like loss of appetite, recurrent respiratory tract infections, and cough, the caring clinicians generally think about more commoner conditions like TB and other things, but these are all called indicator conditions. So although the patient presents with several indicator conditions like anemia, recurrent respiratory tract infections, loss of appetite, loss of weight, the initial presentations, the caring clinicians have not thought of HIV. So this is a common scenario that we see in majority of our patients. They have gone to clinicians about 5 to 6 times, more even 10 times before they present with the late stage of HIV. The clinicians have thought of other common conditions but not HIV, probably due to our low prevalence.
Okay, thank you, Dr. Geethani. Now, your graph shows that there's a rising trend of HIV positive cases in our country. So it is imperative that we diagnose them early and recognize them early and treat before developing the complications. So I would like to ask this question from Dr. Varuni. So what are the common indicator conditions that enable us to recognize HIV early so that we can start treatments?
HIV indicator conditions are actually diseases or infections associated with HIV infection. They can be the AIDS defining conditions or non-AIDS defining conditions. So as you can see in this table, I am pretty sure you all are familiar with AIDS defining conditions here, which are typically occur when your CD4 count drop below 200 or categorized under WHO stage 4. However, it is important to identify other conditions in the right side as well. Because these conditions are frequently occurring with early HIV infected patients with early disease, although they are frequently occurring HIV negative individuals as well. Examples include bacterial pneumonia, aseptic meningitis, seborrheic dermatitis, or hematological conditions like unexplained anemia or thrombocytopenia like. So identifying these conditions are really important because it leads to early diagnosis. Okay. Another one. Can you move the slide? To further explain this, if you can see this data, all these conditions actually having undiagnosed HIV prevalence beyond 0.1%. Actually, the prevalence is more than 1% of many of these conditions. So it is usually in a given subpopulation, undiagnosed prevalence exceeds at least 0.1 to 2%, it is always cost effective routinely offering HIV tests to that particular population. So that is why I told you it's really important to identify, because it's a rational approach to offer HIV test if you come across these conditions in your clinical practice to early, because it's lead to early diagnosis. Yeah. So since we discuss about, can you move the slide? Since we discuss about the HIV testing, I want to highlight few points as well about testing in generally. As you all know, the standard screening test is a fourth generation test, either laboratory-based ELISA or point-of-care test like HIV rapid test. However, now it's not essential to do the Western blot to confirm the diagnosis, because now we use three-test algorithm. We used predefined 3 serial tests in separate platforms to diagnose HIV infection. So that means at the time of diagnosis, then and there at the same place, same peripheral clinic even, we can confirm the HIV diagnosis. So it's really important because it saves the time from diagnosis to confirmation, because Western blot is always done centrally. So
usually it takes time to get the Western blot done.
yeah,
This can be done within
same day, even from a
same
peripheral STD clinic. So same day we can confirm after the diagnosis.
Okay, now our patient who actually was diagnosed of having advanced HIV disease complicating with PJP pneumonia. So Dr. Geethani, so how are you going to manage this patient, this particular patient?
Yes. Actually, this patient presented to us with poor treatment to atypical pneumonia, and his HIV screening was positive, and CD4 count was less than 50. So in that type of a patient, and TB, also basic investigations were done and it's negative. So when a patient presents with this type of a history with low grade fever, especially dyspnea on exertion, with confirmed HIV or even screening positive, it's generally we can clinically diagnose it as PJP and start treatment, because starting treatment early is crucial to save the patient's life. So in this patient, PJP is the next commonest presentation with this presentation. Therefore, without wasting time, we empirically start treating the patient. And on examination also, majority of these patients, there will be hardly any lung signs like in this patient. Sometimes they have, they may be emaciated, oral candidiasis may be there, but there can be fine crackles, but absent of any lung sign. Very ill patient. Sometimes saturation is low, but still when you try to examine, there is hardly anything. And even if you do an X-ray, sometimes chest X-ray could be completely normal, or it may be having some features suggestive of atypical pneumonia and a lot of other conditions as well. If you do HRCT, that will show typical features of PJP, but still it also can be negative at the beginning. They can show diffuse ground glass appearance, sometimes with consolidation, nodules and cyst formation. We can do silver stain and tolidone blue. We also send this in this patient as well, but without waiting for the results, we straight away went for the treatment, and we classified this patient as moderate to severe pneumocystis pneumonia. Therefore, in addition to the treatment called trimoxazole, we also added steroid, prednisolone, because that is crucial to prevent the patient going into respiratory distress. So with that treatment, actually patient showed a very drastic improvement within 4 to 5 days.
Okay, now this patient, it was PJP, but are there any other similar conditions that we need to suspect when a patient coming with the similar presentations?
Yes, I think as Dr. Puldisanayaka correctly mentioned, it's TB. So if the patient is not responding, the first thing we have to think of is TB, reinvestigate the patient with more invasive investigations. So your differential diagnosis is patient presenting with respiratory symptoms, mainly depending on the CD4 count. If the CD4 count is more than 500, it's like any other patient you need to think of. If it is less than 500, bacterial pneumonia and TB are more likely. But when the CD4 drops less than 200, PJP and toxoplasma comes into the picture. When the CD4 goes below 100, then malignancies comes into the picture, like Kaposi sarcoma, non-Hodgkin's lymphoma, and even lung malignancy. When the CD4 drops to less than 50, like in this patient, in addition to the all of the above conditions, we also need to think of atypical mycobacteria, disseminated fungal infections, and cytomegalovirus infection. So if the patient is not improving, we need to reconsider our diagnosis and reinvestigate the patient with more invasive investigations. Especially TB, we need to consider again. Next. So TB can present in a very atypical way among HIV patients, especially when the CD4 drops down less than 350. The cough may be absent, or it may be just a dry cough. Your sputum could be negative, chest X-ray could be completely normal, and gene expert will give a better yield. It's more likely to be positive, but if it is a atypical mycobacteria, then again your gene expert will be negative. So doing a culture is very important in any patient with HIV, because your atypical mycobacteria you can only diagnose with culture. So sending a TB culture is very important, and extrapulmonary disease is very common. Sometimes patient may have fever, weight loss, no respiratory symptoms. Then again we have to think about the TB, it's high in the list. So then we have to think about other symptoms. If they have cytopenias, we may have to go for bone marrow. If they have persistent elevated liver enzymes, we have to go for liver biopsy. Or if they have CNS symptoms, then we have to do LP. Always we have to reconsider TB if your patient is very ill and not responding to your initial management. Especially when it comes to CMV disease, very important that at the beginning, usually we don't send CMV PCR. If the patient is not responding, then we have to consider CMV and those because they are less common. But circulating viremia is very common among HIV patients without invasive disease. So just because the CMV PCR become positive, we are not going to treat for CMV. But this type of patient, if not responding with a positive CMV PCR, definitely we have to think about the possibility of CMV pneumonia. And also in this patient, especially CD4 count less than 50, all patients need to be referred for eye clinic to exclude CMV retinitis, because if you start ART without untreated CMV retinitis, they can go blind. So that will be our next line investigation.
Okay, thank you, Dr. Geethani. Now let's talk about the treatment of this particular patient. So, Dr. Varuni, so how are you going to start antiretroviral treatment in this particular patient? So, what factors do you consider when you are starting antiretroviral treatment in this particular patient and in general? Can you just elaborate how?
Yeah. So actually the current recommendation is the WHO and national recommendation is the rapid initiation of ART. That is within 1 week of diagnosis or as early as within same day of diagnosis. We usually, the preferred first line, we usually use 3 active drugs, and the preferred first line regime is the tenofovir, emtricitabine, dolutegravir, as you all heard. However, if the patient is having opportunistic infections like here, we need to first stabilize the patient with the opportunistic infection management and slowly need to introduce ART. When it comes to PJP pneumonia, like here, the recommendation is to start ART, introduce ART within 2 weeks of OI management, that is Cotrim therapy. So in this case, since our patient was well tolerating cotrimoxazole therapy, we have started ART within 1 week, like after the Cotrim POI management. However, if the patient is having other comorbidities like diabetes, hypertension or kidney disease, like we need to definitely tailor-make the regime from the standard regime. That is actually a very lengthy discussion. I'm not going to touch that, but I just want to highlight few points here. If it is always important to check the drug interactions when we are starting ART. And also, if you are going to introduce new drug to a patient already on ART as well, because the commonly using ART may have clinically significant drug interactions with very commonly using drugs in medical ward especially. That is one aspect. And the other thing I want to highlight is if we are suspecting a CNS opportunistic infections like TB meningitis or cryptococcal meningitis like, we need to balance the timing of ART and OI management and ART, because patient can go into life-threatening immune reconstitution inflammatory syndrome or IRIS if we quickly start ART. So that means we truly need to balance the temptation of starting ART soon as well as OI management. So those are the important points I consider briefly when starting ART in a patient like this.
Okay, now delaying diagnosis of HIV, even in this particular patient, it had been delayed for some reasons because most of these HIV patients are presented to general medical units and the general physicians and GPs. So if you don't suspect, it will delay the diagnosis as well. So delaying treatments will lead to complications in HIV patients. So if someone survived after treating a patient like this, so is there any difference in between initiating treatment early and the late diagnosis at late treatments?
Definitely. There's a huge difference between two groups. To answer your question, actually, I will show you the findings of this well-known STAR trial. What they did was they randomized HIV positive individuals, CD4 more than 500, into start ART immediately and or deferred until their CD4 dropped below 350. Their primary endpoints were severe AIDS defining conditions or severe non-AIDS defining condition or else even death. So as you can see here in the results, all the three primary endpoints were significantly higher among deferred arm. So that means actually after the findings, interim analysis of this study in 2015, due to the strength of the findings, all the global guidelines were shifted from CD4 guided ART initiation to treat all concept. That is test and treat. We just test people and start ART. So that is really important. Can you move? So actually the reason for this is the main pathophysiology of HIV is actually the ongoing immune activation and damage of immune system. This occurs from the very early infection. It starts to occur from very early infection. Therefore, with the prolonged immune deficiency and prolonged viremia, patient can lead to opportunistic infections, malignancies, as well as non-communicable disease like coronary vascular disease due to ongoing organ damage from the beginning. So definitely there's a benefit for the individual patient. But other than that, there's a public health benefit as well, because once we start ART, patient have undetectable viral load with the continuation of ART, that undetectable viral load means transmission is literally zero. So we all know that U equal U, undetectable equal untransmittable. So in that sense also, this can help to hold the epidemic as well. So those are the things.
Yes, there are so many recent advances that we hear day to day of antiretroviral treatment. So, is there any prospects of curing HIV disease?
Actually, that is very interesting area of study over decades. Although we have some promising strategies, it's a bit challenging scaling up them to wider HIV population due to various reasons. However, having said that, I would can you previous another one. Okay, that's right. Okay. However, having said that, I want to say that with the novel ART, HIV is transformed from life-threatening severe disease to easily manageable chronic condition like diabetes or hypertension. So that means with the ART, people can live near normal, actually normal life as HIV negative individuals with a normal life expectancy close to general population.
So it is not different to other chronic illnesses like
yeah,
diabetic
so
and hypertension.
yeah, so they can even marry HIV negative with the virological suppression. They can even marry HIV negative individuals, give birth to HIV negative children, and therefore, actually, although there's no cure, with the new ART, it's like close. It's the impactful of current ART is actually close to the cure.
Close to cure.
So,
okay, thank you, Dr. Varuni. My last question from Dr. Upul Disanayake. As a physician, so what are the type of challenges that you will face and you have faced while managing a patient with positive HIV?
Believing them. Now, we had this similar patient, same case. When this was introduced, I asked them whether it's the same patient that we had in our ward. This guy was recently married, and the wife was pregnant for about 12 weeks when he came with this cough, all that. And we diagnosed PJP pneumonia there, and probably survived. So, believing people, so don't believe them, and ask them, especially when it is a lady registrar who are dominating the field now, they will be reluctant to ask the men, how's your sexual history? Second thing is the stigma attached to HIV. And third thing is our belief that we have to get informed written consent to diagnose HIV, which I didn't know that do not exist now. So we just have to tell them that we are going to check HIV in you. That's it. Just like doing a full blood count and CRP. Then when they are along with our other patients, now they are immunosuppressed, they can easily get other infection from our patient. They don't have special wards, special areas, but that is good. I think they are not then any other illness. They are treated as any other illness in the ward. Probably that's it. We will learn more. And I think most important thing that I learned today is that the investigation for HIV testing is not for AIDS defining conditions. There are other conditions, the common things like anemia, the pneumonias, all that, where you can investigate the patient. One of the additional investigations will be HIV. And it is cost effective to do the HIV testing because the yield is high. Thank you very much.
Okay, thank you, Dr. Pul. My last question of the program from venologist, Dr. Geethani. So in this patient most likely acquired HIV through same-sex behavior. So can you just elaborate what's the current epidemiology of HIV in Sri Lanka?
Yes. as you can see in the slide, over the years, definitely the number of patients who've got HIV from heterosexual transmission is going down, while the number of patients who've got HIV through male-to-male sex is going up. So as a result of that, the male-to-female ratio, as you can see, has gone up to 8:1. And if you analyze the young age group, 15 to 29, it's even more striking. The ratio is 13:1. So this is basically because of the male-to-male sex is the driver of the epidemic. But also we need to keep in mind that this situation can change at any time, especially with the rate of spas that we see in the country. So we always have to keep this surveillance ongoing. We should not keep our attention from other groups as well, but this is the situation currently, the mainly male-to-male sex. But anywhere, if you have unprotected high-risk sexual behavior, HIV is possible. But as in this case, these behaviors or whatever the risky sexual behaviors will not be revealed in the board setup. So going alone with the sexual history may be misleading.
Okay, finally, what are your take-home messages?
I think Dr. Upul also have mentioned important points. I think first thing is whenever they are presenting with indicator conditions, HIV indicator conditions, always do not hesitate to offer an HIV test irrespective of the sexual history, because undiagnosed prevalence of HIV among that particular group is high, which justify your HIV testing, and it's available all over the country, all base hospitals and above, and also especially when the patient presenting with respiratory symptoms, that is one of the commonest presentation of late stage of HIV. They may present in a very atypical way, especially it can mimic things like tuberculosis. Once your common conditions are excluded, please consider HIV as your next possible differential diagnosis, and do not hesitate to order an HIV test. As Dr. Upul correctly mentioned, you don't need to ask written consent, or you don't need to do pre-test counseling as such. Just mention that and make it your standard of care. So if it is the standard of care, you are generally doing HIV for all patients who present with chronic anemia, chronic cough, then I don't think anybody will refuse testing. So that is the way you should have to normalize the testing, offer it to all indicator conditions, then it becomes your standard of care.
Okay, thank you very much. We have already passed our time. Maybe we can allow one question from the audience, maybe one or two questions. If you have any questions, you can raise your hand and you can ask the questions. All right. So we will wind up the session. And before we stop, I would like to hand over the token of appreciations. So I would invite Dr. Priyantha Veerasinghe, President of Sri Lanka College of Sexual Health and HIV Medicine, to hand over the certificate of appreciations to Dr. Upul Disanayake. Thank you, sir. And Dr. Nimali Jayasuriya, Vice President of SL Kosh, please come, and we'll hand over the certificates to Dr. Varuni Pannala.
And to Dr. Sandipana Gamagi. And to Dr. Nalaka Kulatunga.
Okay, thank you very much. Thank you all for the joining this session, and my special thanks goes to our panelists to have for their valuable contribution. And then I will invite Dr. Piumi Pereira to moderate the next session.
Thank you so much, Dr. Sandeepana. So that was actually a very interesting session. Our next case will be presented by our senior registrar, Dr. Irani Gunatilaka, and let me ask our panelists to join us on stage. Dr. Dr. Priyantha Veerasinghe and Dr. Shyama Somawardhana. Let me introduce Dr. Priyantha Veerasinghe. He's the consultant venereologist at STD Clinic Negombo, and he's the president of the Sri Lanka College of Sexual Health and HIV Medicine. And our next panelist is Dr. Shyama Somawardhana, consultant venereologist, STD Clinic, KGOL. So our second case presentation is named as Still the Same Mimicker. So let's see who this mimicker is. Over to you.
Thank you, Dr. Piumi. And this is our patient who is 28-year-old male patient who presented to medical casualty. And he had rash, which is scrotal and penile rash for 2 weeks. And he noticed dark patches on palms and soles for 2 weeks duration. And he had right-sided red eye for few days with no significant visual impairment. And he had mild low-grade fever for 2 to 3 weeks. And there was no joint pains or headaches, and he denied any genital ulcers or urethral discharge in the past. He was treated prior to admission with oral medication and some local application of cream by a general practitioner. These are the investigations which were done at the medical casualty ward, and with them, patient was referred to STD clinic, and his full blood count was in the normal range, and AST, ALT and serum creatinine were normal. Patient was an unmarried male, and he had an IT degree from a private university, and currently he was working in the private sector. In his sexual history, his koitake was at the age of 22 years with an unregular female partner. However, he had 3 male partners over the past 1 year. That means in the recent past, he had male partners, and he had risk behaviors. That means unprotected anal sex, both insertive and receptive, with those partners. And his lifetime partners were 10 male. He had 10 male lifetime partners, and he denied any sexual exposures under the influence of drugs or any history of substance abuse. During the clinical examination at the STD clinic, patient had palmar plantar maculopapular rash, as you can see in these pictures, and he had redness around the limbus of the right eye, which was confirmed as anterior uveitis by an ophthalmologist. And he had cervical, axillary and preauricular lymphadenopathy. On his genital examination, there was a hypertrophic scaly rash on the scrotum and the penis, and he had bilateral non-tender inguinal lymphadenopathy. His abdominal examination was normal with no organomegaly, and central nervous system examination was normal with no cranial nerve involvement. These are the investigations done at the STD clinic. His VDRL test was reactive with R128, and TPPA test was positive with negative HIV screening test. Depending on the clinical findings and the reports, the diagnosis was made as secondary syphilis with anterior uveitis as an isolated ophthalmic manifestation.
Okay, so let me start the discussion with Dr. Priyantha. So this patient presented with a wide variety of symptoms, the skin, eye, as well as non-specific symptoms. So in such a patient that with syphilis like this, why it is important for the physician to know about syphilis?
Yeah, thank you, Pimi. It's a very important question. Actually, syphilis is so fascinating illness. Once the Sir William Osler, known to be the father of modern medicine, mentioned syphilis as the person who knows syphilis knows medicine. And again, the medical literature describes syphilis as the great mimicker. That is not because of anything. Syphilis can present as a wide spectrum of manifestations, can involve many organs, many systems. So in day-to-day medical practice, I mean in the non-venerologists like physicians, neurologists, dermatologists, they can come across various manifestations of syphilis. I mean that is the reason here we are discussing this case. So these days actually we see more and more cases of syphilis, and actually we see some of the new presentations of syphilis. So that's what, I mean, that is the importance of discussing this case today. As we discussed, this is a case of secondary syphilis. So he had a skin rash and generalized lymphadenopathy with mucocutaneous lesions. So somebody with skin rash might present to you, lymphadenopathy, they will present to you. I mean, mucocutaneous lesions, they straight away come to us. So in your point of view, the two conditions are very important. And apart from that, this patient had an anterior uveitis with an isolated manner. That means without involvement of other cranial nerves or the central nervous system manifestation. So that is one of the common manifestations we see in syphilis these days. So these are the important points we have to show you in this particular case. So if I talk about a few things about the secondary syphilis, so that again this is very important. So generally it comes with skin rash, mucocutaneous lesions and lymphadenopathy. And this rash is very peculiar type of rash. Sometimes this rash might not be very obvious to you, right? And generally it's a copper color type of macular rash, usually overlooked by the patient and might not be well observed by the non-venerologist, right? So as we saw in this case, the rash commonly occur in palms and soles, sometimes not visible over the trunk, right? So patient might see it, but you might not observe it, right? So sometimes it can be a sort of a general type of rash with scaly, and sometimes might be follicular in nature. Rarely it can be even pustular, right? So this the generalized type of rash, sometimes you might not be able to recognize it from pityriasis rosea or even guttate psoriasis. So apart from the involvement of the palms and soles, generally in pityriasis rosea and guttate psoriasis, they don't get the lesions over the palms and soles. So apart from these the rash, secondary syphilis, they have other systemic manifestations like malaise, sore throat, headache, weight loss, low-grade fever, body aches, like that. So much of a different the features. So as I said previously, this is the picture of widespread skin lesions we see in secondary syphilis. Usually this is common in white people. But in Sri Lankan context, we don't see this type of widespread involvement so much. And you can see the involvement of the face, and even you can see the involvement of the soles, right? So as I said previously, I mean, this is the involvement of the palms. So this rash is very minor. You might not observe it very well. So somebody actually can miss it. So some of our patients actually they have the rash only in the palms and soles. So be careful when you see a rash only occur in palms and so it could be secondary syphilis. Along with the skin rash, they can have what is called patchy alopecia due to the involvement of the hair follicles by the spirochetes, right? So they present with patchy alopecia. This is the picture of patchy alopecia. So if I talk about the lymph node enlargement, generally they will get inguinal nodes, axillary, posterior cervical, femoral and epitrochlear nodes. So they can have a subclinical form of hepatitis. Occasionally they may be symptomatic. So in that case, sometimes they might present with abnormal liver functions, but generally you won't get it. So the hepatitis would be a subclinical one. So in secondary syphilis, again, they can produce immune complexes in the blood. So that might lead to different presentations of syphilis. For example, even iritis. So when you have antiretrovirus, the main pathophysiology is due to immune complex deposition. Similarly, in glomerulonephritis, nephrotic syndrome can occur in secondary syphilis due to this immune complexes mediated pathophysiology. So what I have to say is, even they present with they could present with glomerulonephritis, nephrotic syndrome in secondary syphilis, but isolated manner of these presentation without any other features of secondary syphilis is rather very rare thing.
Okay, so this patient was actually presented with a red eye and was diagnosed as having anterior uveitis. Dr. Priyantha, would you mind explaining why that symptom is important in a syphilitic patient?
Yes, Piyumi, thank you. So shall I talk to you a bit about neurosyphilis for your point of view, for you to understand it? For this neurosyphilis, I am going to discuss in relation to the venereologist point of view, right? So in that case, you might encounter these different presentations in your day-to-day practice. Then you would think these conditions in your differential diagnosis. So this is actually the from venereologist point of view, in which stage of the syphilis can affect the central nervous system. That form of approach I am going to discuss. So the syphilis actually can infect central nervous system at any stage, the primary, secondary, or later stage. The commonest CNS involvement would be asymptomatic neurosyphilis, where you get abnormal CSF with elevated cells and protein, but patient without any symptoms. So in that case, you don't need any treatment at all. So what you have to do is you have to treat the syphilis according to the stage of the disease. So that itself is cure for the asymptomatic neurosyphilis. And later on, actually, in early phase of syphilis, they might develop what is called syphilitic meningitis, where you see meningitis and cranial nerve involvement, cranial nerve dysfunction. In advanced form of syphilitic meningitis, what you see is bacillar type of meningitis. So you see raised intracranial pressure and some form of a cranial nerve dysfunction. After some time, actually, they might present with meningovascular syphilis, right, where they present with stroke, acute altered mental conditions with element of meningitis, usually after few months to years of syphilis infection. So in which case, in which condition you are sort of thinking meningovascular syphilis is very important. For example, if young male or female presenting with the vascular type of a stroke without any risk factors of without any risk factors, like no history of atherosclerosis, no history of embolic phenomenon, in that case, the meningovascular syphilis could be the cause. So as you know, late neurological manifestations of syphilis, we don't see much now due to wide use of antibiotics. So tapes dorsalis and general paralysis, after about 10 to 30 years of syphilis, they can develop. but generally we hardly see such manifestations. But what we see is these early manifestations and these the ocular and otosyphilis manifestation. So that is very important. So we are sort of seeing more and more ocular syphilis patients now. So that is why we thought of discussing this important case for you to keep that in mind. So commonly the eye and the ocular system can involve with the syphilis at any stage of the syphilis, but very common with the early stage of syphilis. So ocular syphilis can present with involvement of the anterior uveitis with the uveal tract. They might present with anterior uveitis. That is a presentation of this patient. Usually they come with red eye. And posterior uveitis, usually they come with a blurred vision or reduced vision. And panuveitis, that is a combination of anterior uveitis and posterior uveitis. And they might come with optic neuropathy and retinal vasculitis. Similarly, otosyphilis is again very important presentation of syphilis involving the ear. So they usually present with tinnitus, vertigo, and even sometimes they might come with sensorineural hearing loss. So identification of the ocular syphilis and otosyphilis is very important. Unless you treat them early, they can have permanent visual loss or even permanent hearing loss. So if you identify them, we can treat them very easily and we can save their vision and the ear. We can save their eye and the ear.
Thank you, Dr. Priyantha. And so when we see a patient with CNS involvement, we tend to do CSF analysis. Can you elaborate how this CSF analysis usually helps with these kind of patients?
Yeah. First of all, I have to say that the diagnosis of neurosyphilis by doing a CSF analysis is not straightforward. So you have to go with many supportive evidence. For example, so you have to go with the pleocytosis, cells, protein, and different things. So I'll discuss it in detail with these two slides. This discussion is basically I'm doing in relation to your practice, right? So if you see a patient with the eye involvement or the ear involvement, what you have to see is, as in this case, you have to see whether this patient is, whether he got isolated ocular symptoms or whether he got ocular symptoms as a part of the neurosyphilis, right? So if it is an isolated type of manifestations of ocular symptoms, in that case, no CNS involvement, examination of the central nervous system normal. So in that case, you can think about isolated ocular manifestation. So in that type of patient, actually, even without CSF analysis, you can treat. Because this isolated ocular syphilis is known to cause normal findings of the CSF. Very similarly, in otosyphilis, if it's isolated, that means only the tinnitus and vertigo, but there is no 8th nerve palsy or any other central nervous system manifestations. So in that case, you can even go for treatment without having a CSF examination, because we expect them to have normal CSF, because these manifestations are very limited to eye and the ear, not as a part of the neurosyphilis. But the treatment is same. So these isolated otosyphilis and isolated auditory syphilis, we have to treat as neurosyphilis. So if you think about this type of manifestation, what you have to do is you have to do investigations in order to confirm syphilis. And for management of these patients, actually we need close collaboration with ophthalmologists and ENT surgeons. And if I talk about the CSF, the findings in neurosyphilis, as I said previously, that would be, not straightforward. So what generally you see is, you see pleocytosis, that means increased cells in the CSF with elevated proteins. And the level of protein, again, it's depending on the level of CNS involvement. So if inflammation is more, you expect more cells and more protein to be in the CSF analysis. And one very, one important test would be, in venereologist point of view, doing a CSF VDRL. So if you do the CSF VDRL, if it is positive, actually it's almost diagnostic. CSF VDRL is almost diagnostic of neurosyphilis in a symptomatic patient. But the sensitivity of CSF VDRL is very low. So in that case, negative CSF VDRL does not rule out neurosyphilis. That factor you have to keep that in mind. Again, you can do CSF TPPA. The interpretation is other way around. That is not very specific test for neurosyphilis, but having negative CSF TPPA is rather, I would say, strong evidence against the diagnosis of neurosyphilis. So having negative TPPA in CSF, that means your diagnosis of neurosyphilis is unlikely. So in that case, combination of these, all these factors, you might be able to diagnose neurosyphilis in a comprehensive manner.
Thank you, Dr. Priyantha. So now I'd like to turn to Dr. Sharma. Dr. Sharma, shall we discuss how this sort of patient is managed and what are the recommended treatment?
Yes, thank you, Piyumi. As this patient is having features of clinical features and serological evidence of secondary syphilis with isolated eye involvement, we have to treat the patient as for neurosyphilis. And the drug of choice for treating any type of syphilis is penicillin. And in this case, we have to go for aqueous crystalline penicillin treatment, 18 to 24 million units per day. This can be either administered as 4-hourly doses of 3 to 4 million units IV, or we can give them a continuous infusion for 10 to 14 days. And if we are sure about the compliance of the patient, and if he can come without any problem to the clinic, we can also manage the patient as an outpatient with procaine penicillin 2.4 million units IM once daily with probenecid for 10 to 14 days. And that is the standard treatment for neurosyphilis in our setup.
Okay, so as we discussed before, so syphilis, the trends of syphilis seems to be changing nowadays. So that's why we chose this case as well. Would you be able to explain these changes that we now see as venereologist to this audience?
Yes, baby. So I took this graph from the annual report of the National STD AIDS Control Program, and you all can see that there's a rising trend of most of the major STIs from 2020 to 2023. And viral STIs like HSV and human papillomavirus infections tops the list because mainly due to their recurrent nature. And but the most important thing is the two major bacterial STIs, namely gonorrhea and syphilis, are on the rise. We can see a rising trend from 2021 to 2023. And this is also very important because we take the rising trend of bacterial STIs as a proxy measure for recent unprotected sexual exposures among our clients. And when we move to the trends of syphilis from 2019 to 2023, you can observe an alarming rise of syphilis cases among males, especially among males more than 25 years from 2021 to 2023. And our patient also is in this same age group. And in the previous years, we have observed syphilis cases, but they were mainly asymptomatic cases. Majority were detected during pre-employment screening, visa screening, or antenatal screening. But the trend has changed now. In the recent past, we see a lot of men coming to our clinics, young males who are having sex with men, and they are coming with symptoms. Sometimes they come with primary chancres and rashes of secondary syphilis, And recently we have seen a lot of cases of people coming with features of secondary syphilis with isolated ocular ear involvement to our clinics. So that is the trend of syphilis at the moment.
Yes, and from all this information, we can say that this patient is a patient with high sexual risk to acquire HIV. So, can you explain what are the other management aspects that we have to consider in such a patient?
Yeah, if a STD clinic attendee is diagnosed with STI or with irrespective whether they are having STIs or not, we give them the complete comprehensive care package. And in this patient specifically, we have to do the partner notification and trace their partners, and we have to treat them epidemiologically, irrespective of the partner's serological status, because the patient is having infectious syphilis. And also we have to follow up this patient 2 years post-treatment to exclude any reinfection or relapse. And as for all STD clinic attendees, we do HIV screening, and in this case he is negative. And then he is eligible for the biomedical interventions such as pre-exposure prophylaxis and post-exposure prophylaxis following sexual exposure for HIV. And also we stress or we emphasize them on using behavioral interventions including condoms. And I'll give you a brief introduction to HIV pre-exposure prophylaxis. We call it PrEP. This is available in all the STD clinics and few community clinics. And this pre-exposure prophylaxis for HIV is indicated for individuals with increased risk of HIV acquisition. And in this, our patient, he has had multiple sexual partners, and he has had unprotected insertive and anal sex, which has the highest risk of HIV acquisition. And he was diagnosed with secondary syphilis in the recent past. So he is eligible for pre-exposure prophylaxis. In Sri Lanka, we are using the fixed dose combination of tenofovir and emtricitabine in two different regimes. One is the single daily dose regime, and the other one is event-driven or on-demand PrEP. And but the thing is, event-driven on-demand PrEP is recommended only for men having sex with men, and all the other high-risk groups, they can have a single daily dosing of PrEP. And cabotegravir injections every 2 months is also available in other countries, and it is recommended for people with poor adherence to oral PrEP. Unfortunately, it is not available in Sri Lanka at the moment. Okay, I'll give a little bit of detail about the event-driven PrEP and single daily dosing of PrEP. The first one is the event-driven PrEP. This is recommended for men having sex with men, and for that they have to take 2 pills of tenofovir and emtricitabine. There's a double dosing, 2 to 24 hours prior to their planned sexual exposure. And after the exposure, they have to take 1 pill daily for 48 hours to prevent HIV acquisition. And if they plan to have sex beyond the 24 hours after the 2 initial pills, they have to continue 1 pill daily till they cease their sexual exposures, and then they have to continue 1 pill daily for 48 hours as a tail period. And for people who are using single daily dosing, the lead-in period is 1 week. They have to take a single pill daily for 7 days for them to get the enough concentration of the drugs in the genital secretions, and then they can have sexual exposures, and they have to continue single daily dose until they cease their sexual exposures, and as a tail period they have to take single daily dose for 1 week further to prevent HIV acquisition. And I'll give you a brief introduction to post-exposure prophylaxis of following sexual exposure as well. We call it PEPC or NPEP, that is non-occupational post-exposure prophylaxis. This has to be taken as soon as possible, within hours, and within 72 hours to get the maximum benefit. And for Pepsi, we use 3 antiretroviral drugs for 28 days. And the patients or the clients are followed up with HIV testing for follow-up at 6 weeks and 12 weeks. And currently we are giving Pepsi for people who are having unprotected sexual exposure with high-risk partners, and for victims of gang rape. And there are a few indications for prescribing Pepsi in STD clinics nowadays.
Thank you, Dr. Sharma. So that actually concludes our case discussion on this great mimicker. So let me read out these take-home messages actually. So you all can see that syphilis, even though it is a STD, it still can present in your wards. So keep syphilis in your mind as well in your day-to-day practice. And Sri Lanka is now having these biomedical interventions for HIV prevention, like this pre-exposure prophylaxis and post-exposure prophylaxis. So if you see a eligible person, or if you find a eligible person, please direct them to our STD clinics so that we can offer them all this treatment. So thank you. And now I would like to invite Dr. Upul Disanayake, President of Ceylon College of Physicians, to give away the certificates of appreciation. To Dr. Priyantha Veerasinghe, consultant venereologist. And Dr. Shyama Sonawardhan, consultant venereologist. I would now like to invite Dr. Chiranthi Liyanage, the Secretary of Ceylon College of Physicians, to give away the certificate to Dr. Irani Gunathilaka. Senior Registrar, who presented the case. Thank you.
And finally, to the moderator, Dr. Puri.
Thank you, Chiranthi. And so, because you all know that we only have a very limited number of venereologists, so I'm going to moderate the next session as well. So let me invite Dr. Manjula Rajapaksha and Dr. Nimali Jayasuriya, the panelist for our third case. And Dr. Lalantika Velivitiya, our senior registrar, is going to present the third case, Revealing Unseen Shadows. No, it's not a horror story, it's just a case presentation.
Our patient is 35 years old.
Dr. Lalantika just. So, Dr. Manjula Rajapaksha is the consultant venereologist from the STD clinic, Gampaha. And Dr. Nimali Jayasuriya is the consultant venereologist and the EMTCT coordinator for the National STD/AIDS Control Program. Okay.
Our patient is 35 years old widow from Dehiwala. She was referred from a medical ward following dermatological opinion for HIV and STI screening. She presented with low-grade fever for 4 weeks duration with generalized papular rash for 4 months and vortipapular lesions on forehead and face for 2 months. She also had weight loss with mild loss of appetite. This patient had been to several clinicians for the skin rash and also for the facial papules with poor response to treatment. And she had no any other symptoms in other systems. And there is no history of chronic cough, excessive night sweats, or contact history of TB. Investigation for pyrexia of unknown origin was initiated while in the medical ward. There was no significant past medical or surgical history. She had an uneventful gynecological and obstetric history with 2 uneventful normal vaginal deliveries. She owns a textile shop. She is a mother of 2 children. Children were 4 years and 10 years old, and there is no history of sexual promiscuity. Her marital partner was an accountant. Actually, he was passed away 1 year ago at the age of 38 years of age, but his cause of death is not known to patient, probably due to severe pneumonia. On examination, she was febrile and not pale, not icteric. She had no lymphadenopathy. There was a generalized patchy papular rash, mainly on upper and lower limbs, and anterior trunk, probably pruritic papular eruptions. Multiple pinkish papular rash over forehead and face were there, suggestive of facial molluscum contagiosum, and other systemic examination were normal. These photos were taken at presentation that upper limb and trunk rash suggestive of pruritic papular eruption, and other 2 pictures show facial lesions suggestive of molluscum contagiosum. She undergone all these basic investigations. Full blood count revealed bicytopenia with anemia and low platelet count. Blood picture also indicate anemia with features of iron deficiency and a possibility of ongoing viral infection. There were few toxic neutrophils, and also advised to exclude thalassemia trait if no response to iron supplements. Other investigations were normal, and TB exclusion was done with normal chest X-ray, and sputum gene expert also negative. In about 1 week after admission, patient was referred to our clinic for HIV screening following dermatological opinion. And HIV 1 and 2 antigen antibody rapid screening was positive, and same day confirmation was done by 3 HIV test algorithm. And her CD4 count is 197 with a 96,000 of viral load. Syphilis screening was negative, and also hepatitis B and C also negative. She was diagnosed as retroviral infection with severe immune deficiency. Actually, she was in WHO clinical stage 3. She was started on antiretroviral treatment with adherence counseling. Topical steroids and antifungal treatment were given for the skin lesions, and also given antihistamines due to pruritus. And cryotherapy was given for molluscum infection. She was started on cotrimoxazole prophylaxis for the PJP infection. Nutritional support and supplementation were given, also treated with iron supplements. In summary, she was 34 years old lady. She was a recent widow. Marital partner's cause of death was uncertain. She was a mother of 2 young children. She had pruritic papular eruption, molluscum contagiosum infection, and pyrexia of unknown origin. She accessed health care for 4 months with no success, eventually diagnosed with late stage HIV infection directed by dermatologist.
Thank you, Lalantika. So, pyrexia of unknown origin is quite a common clinical presentation in our setting, and we see a lot of PLHIV presenting with pyrexia of unknown origin. And also, as in the first case scenario, we see some missed opportunities in this case as well. So, Dr. Manjula, would you like to explain or elaborate on these missed opportunities?
Yes, thank you, Pumi. And so even though the duration is not that long like the first patient, our patient also had a 1-year history of suffering without diagnosis. So I can see several missed opportunities in this lady as well. So firstly, if we take her history, so she had a 4-month history of stage 2 HIV illness, which is the pruritic papular eruptions and the molluscum contagiosum extragenital in the face. And also, finally, that progressed into 4 weeks history of fever of unknown origin. And again, there were like her marital partner, whether we have missed the diagnosis of his marital partner, and where we could have diagnosed her early without suffering for the last 1 year. And also queried whether we missed her diagnosis during her pregnancy. She has 2 children, younger one is 4 years of age. So whether we have missed her diagnosis during the pregnancy. So if we consider her clinical scenario, so 4-month history of stage 2 HIV illness with the papulopruritic eruptions and molluscum contagiosum. So PPE, the pruritic papular eruption, is a well-known clinical phenomenon as resulted by HIV, which happens in the early course of HIV, where they do not have very severe immunodeficiency, usually in the stage 2, where the patients present mainly to the general practitioners or the dermatologists. So in addition to the pruritic papular eruptions, there are many herpes zosters, angular cheilitis, so these kind of dermatological manifestations happen. So she had been to many clinicians, maybe general practitioners, maybe specialists, we don't know actually. So lack of awareness of these HIV-associated conditions had missed the diagnosis. And also the molluscum. So molluscum contagiosum caused by the pox virus in adults, actually even though it's common among children, adult molluscum contagiosum is considered as a sexually transmitted infection. So we see it in genital manifestations as a result of sexual contact. But to see when the extragenital molluscum happens, we have to think twice whether the patient has some kind of immunodeficiency, because the literature clearly says extensive molluscum or the extragenital molluscum is associated with HIV. So in her history, actually, she had been to several physicians, but we have missed the diagnosis at that time. So then actually it has led up to the later stages of she had chronic ongoing fever for some time. So since there was no success in the OPD management, she had to get admitted to the ward. And there also, fortunately, she was referred to the dermatologist, where they have suspected this extragenital molluscum can be due to HIV, and suggested the HIV screening as for the fortunate of the patient. So the reason there, I think, it's the not considering the HIV in the differential diagnosis of your PUO investigation list. So actually in this case, she was fortunate. So we have seen sometimes we have been investigating patients with all the baseline things, and also had gone to the bone marrow level as well. So even after the bone marrow, when there is no clue for the diagnosis, then do the HIV screening. So the stage 2 and the 3 illnesses. So as we discussed in the first case, it was a late stage with indicator conditions, but we have to always keep in our mind that the milder disease can manifest as stage 2 and 3 diseases, where especially the stage 2 diseases come to you as general practitioners or physicians. And so I think the main reason, not thinking about HIV or not considering HIV in a differential diagnosis, specifically in her case, is considering her as a very low risk of HIV. Why I've said that is, as Dr. Upul previously said, so she is a middle class ordinary female, maybe faithful to her husband and having a good family life with 2 children. She's not a commercial sex worker. She's not using drugs, or she's not a Middle East returnee, because we have seen that rather than the clinical indications, the physicians are always led by this epidemiological risk. So if they are not fall into these kind of risky traditional risky categories, they are not thinking about HIV in this patients. And also she has a monogamous relationship without any promiscuity, as you said, even though we don't like that saying of promiscuity. It's better to mention as she had single partners or multiple partners. So all these put her, I think, put down the HIV in the very low in the differential diagnosis list. So it in a way it's correct that as Dr. Geethani also previously showed, the men are the main drivers of HIV epidemic in this country. And you can see women all the years had been in a kind of a bottom line, stable all over the years. But the thing we have to identify is, this was also shown, so last year, 62% of men acquired the HIV infection through male-to-male sex. But in Sri Lanka, we know there are no, many of men are bisexuals. So what they do is they act as bridges. So the majority of females, nearly 100% of adult females get the HIV infection through heterosexual transmission through their spouses or husbands. So these men who are bisexual, bridging between the men and women and transmit the diseases to the women. So this indirect risk of HIV transmission also we have to think about. So the third thing actually is whether we have missed the diagnosis in her husband 1 year ago. So Lalantika, do we have any clue to see what was the presentation of her husband and to see whether it's related to HIV?
Yes, madam. Her husband was ill for a few months and he also had loss of appetite and loss of weight. And according to the patient, that her husband has had several hospital admissions, but cause of death is not known by her. According to her sayings, most probably pneumonia is the cause of death.
Yes, so history was not very clear by the patient, but apparently it seems like this was like a first case we discussed. We have missed in the OPD setup or maybe in the ward as well. So if we to diagnose her partner at that time, actually we would have diagnosed this lady as a sexual contact of her husband. So we have missed this diagnosis of her husband, probably to the same reasons in the previous case discussed. Faithful husband, accountant, doing a good profession, and having 2 children, running a good family life. So we have not categorized him as having an epidemiological risk of HIV. So here we want to highlight that it's not the profession. It may be, there may be accountants, there may be doctors, nurses, engineers. So it's not the profession, it's the behavior. So it's the sexual behavior actually put you at risk of HIV. And the other thing is whether we have missed this diagnosis during pregnancy. So any evidence to see whether we have tested her during her, at least in last pregnancy?
Yes, madam. This mother was tested in both pregnancies according to the patient, and they were negative, but there were no records available, madam.
Okay, so apparently that we have done according to mother's history, so it might be reliable because the preliminary care midwives or the MOHs, they reveal the status with the mothers and record it in the antenatal record. So we can think that she was negative at that time, nearly 4 years ago, she was negative.
Okay, thank you, Dr. Manjula. So, so this is a woman living with HIV. So in such situations, there are so many things that we have to think of when managing them. Dr. Nimali, will be able to explain the aspects that we have to think of when we are managing a female patient?
Yeah, one of the main adverse outcome among HIV positive pregnant women is possibility of mother-to-child transmission of HIV. Actually, it can be inside the uterus during delivery as well as through breast milk. And we see the risk of HIV transmission during the course of pregnancy and during the breastfeeding time. So the risk is 1% up to 14 weeks. It's actually very low risk up to 14 weeks. And 14 to 36 weeks, it's 4%. And 36 to until labor, actually it's around 20%. That is the highest risk. And if the baby breastfed for 2 years, the risk is 10%. And that is the risk. Actually, we say that overall risk is around 35 to 40% in low income countries. So in Sri Lanka, actually, all pregnant mothers should undergo HIV testing, ideally during first trimester before 12 weeks. And also we recommend to have a second test if mother is at like in a risk population, or if like mother is having recurrent STIs or the partner is at a risk or something, then we recommend to have a second test closer to delivery as well. Actually, the objective of screening these pregnant mothers is to, if we diagnose, we can start treatment. Then when mother come to undetectable viral load or the viral copy is less than 50%, the risk is actually, we can say there is no risk of transmission to baby. So that is the objective. And actually we have started this screening program in Sri Lanka in 2012, now 2024. There are actually more than 250 babies born to HIV positive pregnant mothers. Fortunately, all babies are negative due to this program. And also, Sri Lanka is a country that eliminated mother-to-child transmission of HIV and syphilis since 2019, and we actually maintained the indicator successfully until now. And actually, so we are going to eliminate hepatitis. We are going to start elimination of hepatitis B among pregnant mothers. Will be starting from next year onwards. Actually, in this case, the mother, according to mother, she said that babies was during antenatal period. She was screened for HIV, but anyway, we have to screen both children as well. Dr. Lalantika, were they screened for HIV?
Yes, madam. Both children were screened for HIV, and both were negative.
So then we can confirmly say that the babies are negative.
Okay, so then, so one of the other things that we see in managing these patients are the stigma and discrimination. Dr. Upul also mentioned it in the first case. So this is actually one of the main challenges we see in the clinical setting. So Dr. Nimali, would you mind explaining the reasons for the stigma among the healthcare staff?
Actually, stigma against HIV have many reasons. The first or the most important reason is the lack of aware or lack of misinformation regarding the HIV transmission. That people actually they think that the HIV can be transmitted through casual contact. It's not like that. HIV can be transmitted only through sexually, maybe oral, anal or vaginal, and through blood or blood products, maybe donation or needle prick or splashes, and through mother-to-child transmission, but no other ways of transmission of HIV. And the next thing is again the stigma against some behaviors, especially among high-risk groups. So as other doctors says that the HIV is more among the men having sex with men. And also it's the behaviors of the certain groups like female sex workers, transgender people, and injecting drug users and men having sex with men. Actually their behaviors are very much at a risk for HIV. So actually those behaviors also stigmatized by our culture or the culture or the Sri Lankan setup. So because of that actually stigma against those behaviors, eventually the stigma against HIV as well. Other thing is, the people think that this is not our disease, this is their disease. It's not like that. So anyone can get the disease because you may be not at a risk, but the partner may be at a risk. The next thing is the other reason for stigma is they actually think about HIV positive patients, they are having some bad behavior, or their behavior is not a good behavior. So because of that, they are stigmatized. Those are the most common. The one most important thing is the historical fear. From like early stage of disease, actually it's like deadly disease, till those myths and misconceptions actually continue. So there are new knowledge, and also we have to get those knowledge and get rid of this stigma.
Yes, and then this stigma can affect in a very bad way when we are managing the patients in the healthcare setting. Will you be able to explain more about that?
Actually, the main problem is when they stigmatize, they avoid get tested. So the HIV testing is the most important thing, and this is the entry point for HIV treatment care and also for HIV preventive services. If they get tested, if they're negative, they can go to preventive services like PrEP and all, condoms and all, and they can continue their negativity. If positive, actually, they have to have treatment, and it's a lifelong treatment. They have to actually the main objective is to have a healthy life of the patient and also to prevent transmission as well. So if they not get tested, then there's a risk of transmission to other. The next thing is actually they not disclose their status to, especially for the healthcare workers. Even like they will come to your hospital, but they not disclose their status. That's again a problem. And other thing is they are not willing to disclose their partners. It's the partner management is also very much important. Sometimes if they stigmatize, they think that so they are not like, or they are, especially the husbands, they don't like to have their partners also getting stigmatized by this infection, so they don't disclose their status to their partners as well as to the healthcare workers to trace partners as well. So those are the main outcomes of stigmatization. Actually, I want to tell one example. The Dr. Upul's patient, actually the husband not survived, and the pregnant mother, she was 12 weeks when she knew that she was HIV positive, and actually she was remarkably self-stigmatized, and she actually didn't want to come for our services as well, and also actually not willing to go to DMH as well. So with great difficulty we managed that pregnant mother. Because of actually fear of stigma, she was not willing to come for the services. Finally, the baby born, and the baby was negative. So that's one of the adverse outcome of stigma.
Yeah, so it's not just the external stigma, there's some internal stigma as well that we have to address when we are managing our patients. So, Dr. Manjula, our slogan is to have zero stigma towards PLHIV. So, can you discuss how we can achieve this?
So the zero stigma won't be actually happening in near future, so because it is okay to have stigma. So stigma is in our mind, but the thing we see is to show it as a discrimination. So unless if you can keep your stigma inside yourself, that's okay without discriminating the people. So in the clinical setup, what we have seen is whatever said and done, it's the fear of infection we get. That's why we tend to stigmatize and discriminate people in the hospital setups, OPD setups, or in the in-ward setups. So how to overcome is to have, I propose to have the correct and updated knowledge on HIV. Not only the HIV, actually, the STD patients are also, we know, discriminated in the clinical setup. So we have to have the correct knowledge. The correct mode of transmission should be known. We know HIV is not airborne. We discussed about the transmission modes before. So, and the knowledge should be updated as well. So you heard about the U equals U slogan. It's not like a community slogan. It's come from the very scientific evidence. So we know that when the patients are stable with undetectable viral load, the transmission is 0. So the updated knowledge we should know to minimize the stigma. And the other thing is, we have to go before that. Yeah. And also, on top of that, we have standard or universal precautions. So as the healthcare workers, when we are get into our profession, we know that we are handling infectious or potentially infectious materials. So that's why the standard and the universal precautions are there, from the hand washing to the gloves to the goggles and the personal protective equipments. We have to use those. And without stigmatizing people, we have to see everybody, every blood or the body product is potentially infectious. So we have to take precautions for that. So even though we do the protection, sometimes accident can happen. So occupational injuries can happen. So that's why we have post-exposure prophylaxis. Shyama discussed about the Pepsi, that non-occupational post-exposure prophylaxis. So here we talk about the occupational post-exposure prophylaxis, where after an occupational injury, it may be due to a needle prick or a mucous membrane exposure. Then occupational PEP is available in all the hospitals above the base hospital level. It's available 24/7 at a 24-hour functioning unit in a hospital. So post-exposure prophylaxis is also available. So basically what I feel is, it's not about the knowledge or the updated knowledge. We have to have the change in our attitudes as well. So whatever we say, the attitudes of even among our healthcare workers, we have seen. So we can have our personal views or attitudes, but we are in a profession. So as professionally, we can't have those personal attitudes or beliefs come into our practice. So we have to act professionally. So I think that is the basic way of avoiding stigma in the clinical setup.
Thank you, Dr. Manjula. And I also would like to invite you to give us our take-home messages for this case.
So as a take-home messages, like in the first case, what we have to emphasize is, don't be misled by the low epidemiological risk. So go on your clinical judgment, your clinical assessment. If you think this can be due to HIV, go ahead and test. So there is no indication for informed written consent. If you are a clinician, if you decide I need to do a HIV testing, go ahead and do it. So you have to inform the patient that I am going to do it because it is indicated, like we are doing for the full blood count or the ESRs. I don't know whether you are informing that to the patient. And also to have a very low threshold if it is clinically indicated. And so for the pyrexia of unknown origin, don't wait until all the test becomes negative to think of whether it can be HIV. Do it as a baseline panel of pyrexia of unknown origin. And also as clinicians, help to reduce the stigma and discrimination towards the HIV, people living with HIV, which will improve the diagnosis, also linked to care and retention in care. Thank you.
Thank you. And I think we have just under 1 minute for a question, if you have any burning questions. Okay, in the absence of questions, I would like to thank Dr. Manjula and Dr. Nimali for discussing this interesting case. And to give away the certificates of appreciation, I would like to invite Dr. Chanaka Abhiratna, Secretary of the Ceylon College of Physicians, Dr. Manjula Rajapaksha. And to Dr. Nimali Jayasuri. And then to the Senior Registrar, Dr. Lalantika Veliviti. Thank you so much.
Final certificate to Dr. P. Pereira from CC.
Thank you. Next is the concluding remarks by Dr. Upul Disanayaka as per the agenda.
And thank you very much, the College of Sexual Health and HIV Medicine, and the College of Physicians and Dr. Sandeepana Gamage for organizing this wonderful event. It opened my eyes to a lot of things that I didn't know. Mind you that I am retiring in the middle of next year, and I am still learning about the things that I don't know. I don't know when the learning would finish. But it was important that we learn this today because there are a lot of gaps in our knowledge. Now with the improvement in the gaps in knowledge, we would do better in our patient care. And one more question. Are the condom vending machines there or they are not there? They are there. Where are they? I have seen one in front of the SCD clinic. Is it functioning? That's great. So it's in your clinic, is it? So they have to insert a 5 rupee coin or 10 rupee coin there? That's great. Say, and because of this so-called 2,500 rupee culture, we can't sort of break that barrier. That's a problem. We sort of show that we are cultured people, and we consider some of the practices uncultured. And therefore, it is difficult to sort of break these barriers. So we'll do it somehow. Thank you very much.